All attendees are in listen-only mode.
Good evening, Rich. How you doing?
Good evening, Dr. Yatros. I'm doing very well, thank you, here in Texas. How you doing in Florida there tonight?
Very, very well. We're excited to talk about dental sleep medical billing, rather. I want to congratulate you on becoming a grandfather today. Makes life different and makes me feel old. I don't know about you, but congratulations, buddy.
Yeah, go ahead and send that Geritol. Send me a case of that Geritol if you would. Thank you.
All right. We're excited to have everyone on here. We've got a really big group. I know several hundred people responded they're going to be on here tonight. We're going to be talking about for the next hour about dental sleep medicine billing. It's one of the 4 pillars that we always refer to as far as how you become successful in dental sleep. You screen, test, treat, and bill. So we're going to be talking about billing. It's one of our most attended subjects, and it's really one of the most important, obviously, if we want to do this in our practices. We will be answering questions throughout the night. We have our dental sleep medicine billing team. Lisa with 4 Pillar Billing, our manager of the 4 Pillar Billing, is on to help us answer some questions. If you want to put the questions in the question box, just type them in. We will address them either in writing or verbally out loud here as we get going. Rich, does your team ever feel like this?
Well, they certainly did, Guy. The first time I, came back from the first course I took and said, hey, we're going to, I used to be, Guy, when I'd come back from a seminar on the weekend or something, we'd have our little huddle meeting on Monday and they'd go, what do we have to start selling now? Bleachy,
Right.
Well, what are you the new expert on, So I certainly think, like you said, Guy, this is our most attended webinar. This is what people, I think, have the biggest challenge with in sleep medicine. And we're just going to try to break it down for you a little bit, but understand that it does take some work, but it's not impossible.
Yeah, we don't want you to feel like this. There is a burden here, but we are going to help you with it today. We wish you luck with it. And, we talk about things we do in our office, and we look at the things we have on the list here. And I know, Rich, you and I don't do a lot of these anymore, but when I talk to a dentist in person, we do a lot of hands-on courses. We look at these things and say, hey, do you feel uncomfortable doing crowns, root canals, implants? And no, they all just say, no, this is routine for us. And I think that's because it's something they do every day and they're trained for. And then I ask them, well, how would you feel if you got sued? Would you feel confident being your own attorney, or do you do your own taxes or build your own house? And we have a conversation. I said, well, no, I think I probably need help with those things. And it's because they haven't been trained to do it. They don't do it every day, and they need help. And so the short answer today is that if you really want to do this, please, we're going to teach you a lot tonight. So don't just turn it off after I show you the next slide. But we really recommend that you get some help with this, because we're going to give you a high-level view and even a little bit lower-level view on how to do this. But, Rich, we've consulted with tens of thousands of dental offices by now, I would assume. And I would say the number one hurdle that they run up against is they try to do this on their own, because they think because they can do dental billing, that equates to doing medical billing. And it's just like doing a root canal versus doing your taxes. It's totally different. And I think it's something that a lot of mistakes are made in that area.
I think it's a combination of both of those things, Guy. I think number one, what makes each of us good in our own way is knowing our limitations, what we can and can't do. Those dentists who hire consultants and coaches and things like that, they tend to do better than dentists who don't, because it's very hard to do dentistry all day and then be a practice manager. If you're not fortunate enough to have somebody who really helps you manage your practice, then it makes it a little bit harder. And I think that there's that burden too. So if you're a dentist out there and you're thinking, oh, I'm going to add 2 or 3 dental devices per week to my practice, which is a very doable thing, but I'm not going to change my staff at all. Now that makes it harder, because this stuff does take time and it takes an effort.
Yeah. And so we know that the offices that work with third-party billers tend to succeed more. I can even say it the opposite. If you don't work with one, your odds of succeeding and being happy with your billing procedures become less. And so we're fortunate to have Lisa from Four Pillar Billing on. We get some questions. We'll even get her to answer them as well. Rich, I put this PowerPoint together, and you and I do things a lot alike, but not exactly the same. So you're going to get a couple people's views on this. And I think this slide is different than the last time we did this webinar. We're always trying to find a better way to do this within the legal guidelines of what's out there. And I'm going to talk about some changes I've made in my practice and a lot of the practice we consult with that a year ago when we did this webinar, this wasn't true. What they are is the four things here about accepting assignment of benefits, easier 486 options and a provisional options, and then gap insurance. I'll talk about that last one first, and then we'll talk about the other three. But I used to always go for gap insurance. I'm out of network, and the first thing we do, let's try to get gap coverage. And you'll see as we go through some flow sheets on how you should discuss this with your patients, if I can tap into their out-of-network benefits, as long as you're out of network, which most of you probably are, and we're going to talk about the difference, why go through, delay the process for 1, 2, 3 weeks, a month, but trying to get gap coverage and then ultimately maybe get less money for the procedure? So that's one of the things that we've changed. And then this accept assignment of benefits. Now I know, Rich, you're in network with what, three or so offices, and we're going to talk about those differences in a minute.
Yeah.
Three or so billers, rather. I'm sorry.
Let me add to this too, Guy, that we are recording this in October of 2019. So
yes.
Sometimes, people listen to these things a couple years later and they go, what the heck is wrong with those guys? So, make sure that it hasn't changed since then, because just like Guy said, this is different than what we presented a year ago. And there's no doubt in my mind, Guy, that it will be different a year from now, as we kind of play the game. It's almost like a chess board, and they say, we're going to do this, and then we figure out, how to do that. And in no way, form or fashion are we ever going to recommend that you do anything illegal or that you play the game in a negative way, but you do have to play the game. And we're just going to try to help you do that while you stay above the bar.
And you get to choose how you do that. We're going to give you some options today about how you play this game, and you got to find the right way to play it that you're comfortable with. I think that's a big part of it. You and your team have to embrace this whole idea and the system that you have. You need to have a system, and you need to embrace it. And one of the things that we've changed within our system is this accept assignment of benefits. And let's explain what that is first, because I think a lot of dentists, I just got back from Long Island, New York. We taught a room full of people about this, and I don't think they really understood. It was obvious they didn't fully what this means. There is a place for you to check when you fill out your medical insurance claim form. I forget the box number off the top of my head, but and then DS3 in our software, it's in the info page. And basically, you can accept the assignment of benefits, or if you don't check it, check this box, then you don't accept the assignment of benefits. And what does that mean? Well, the first thing it means about the money. If you accept the assignment of benefits, then that means typically that the checks will usually come to you in your dental office. So the insurance check itself will come to you. And if you don't check it, then the checks typically go to the patients. Now, you notice I put usually here. Sometimes the checks will still go to the patient, even if you accept assignment of benefits on a patient. But that typically directs where the money's going. And I think most people know that. You accept it, the money comes to you. You don't, the money goes to the patient. But what I think people don't understand, and we're talking about commercial insurance, and we'll talk about Medicare separately. But for regular commercial insurance, when you accept the assignment of benefits, you are, in fact, going into a contract of sorts with that insurance company. You're accepting the terms of their insurance and even possibly or even likely the allowable amounts that they're going to allow.
Very likely the allowable
Very
amount.
likely.
Which may be $700 if you're in Texas and it's Blue Cross Blue Shield. So yeah, that's a big deal.
Yeah, even if you're not in network with them, then you're accepting those benefits. So when you accept that, you get the checks, but now you've got to play by all their rules, and you've got to accept the allowable amounts that they determine, and you've got to have all the boxes checked and provide all the data they say. Now, if you don't check that, then we call that courtesy filing. You can just file in the claim for the patient, the checks go to them, and you really don't have a strong obligation to the insurance company because all you're doing is submitting the claim on the patient's behalf. So, well, if you work out a financial arrangement with that patient, that's between you and the patient, and those checks going to the patient are between them and their insurance company. So I think you've got to get that concept down. And what we've changed, or at least I've changed in our office, and again in 2019, is that I used to always accept this, and the checks come to me, but then my hands are more tied. So more often than not, we don't check assignment of benefits, and we'll explain that in just a little bit. Do you have anything more to add on that?
No, and this is if you're out of network, of course. So we'll talk a little bit about being in network. So Guy has got his practice all going on an out of network model, and I'm kind of switching mine over to mostly in network model. And there are advantages and disadvantages to each. So what we want to try to get across to you tonight is, you know, what are the pros and cons of this? What are the pros and cons of this? You talk to your staff about it. We're just going to try to help you guys figure it out, and then we're happy to help you in any way that we can as well.
Absolutely. And the other thing that I've changed because I am out of network is I try to have pricing options available for our patients. So we have kind of a higher tier plan, which maybe includes some of the milled devices, the 3D printed devices, the ones that cost a little more lab bill. We might do a little more follow-up as far as doing sleep testing, and we might actually in our own office warranty those devices longer. And then we have another plan for the patients who can't afford that, so that we can still get them in a device and get them comfortable and get their airways treated. And then we always have the real fallback is if they really have really poor benefits and they really have financial concerns, we'll make them a provisional device. You can pick the one you choose. I have a MyTap on the screen here. We make them a device to get their airway open, let them see how good that can feel, see how they feel and thrive better. And they wear that for a period of time. And then if they see the benefit, then we can move to a more traditional custom-made dental device. So between those three options, we have the ability to get a lot of patients treated, even if their benefits are less than ideal, and even if their finances are strained a bit. So, little housekeeping. You will get CE for this, and it will come to your email within the next 48 hours. So give it a couple of days, but usually you'll get it much quicker than that. If you don't see it, please check your spam folder. That's where it usually ends up. And if you don't find it there, then by all means, give us a shout, and we will help you with that.
So we've been doing this a long time, Guy and I have, you know, close to 20 years now. So, you know, we started, you know, dental sleep solutions in DS3, you know, several years ago. So we've always said, just like Starbucks, you know, we're going to be an overnight success in 30 years. But, you know, we do a lot of this. We've made a lot of mistakes over the years. You know, I think those of you who know us and have sat in on our webinars and our courses, you know that we're just ordinary guys that are just trying hard to do this and trying to help other people do it. So we certainly hope you get something out of this, and know that we've been doing this for a long time.
Yeah, we don't know everything, but I think we certainly know a lot, and we know what not to do, which is one of the most important things. And we're there for you if you need us. And we're real thrilled to work with Dental Services Group. I've been working with them for, gosh, as long as I can remember. I know, Rich, you have been as well. It's one of the bigger dental labs in the country. But what's nice about them is every time I've interacted with them, any of our people we consult with have interacted with them, that you get the small lab customer service. I feel like they take a big interest in dental sleep devices. They've been doing them for 25 years. They do all the devices that at least I do in my office. I think pretty much the ones that you do in your office as well. So you don't have to go from lab to lab to lab. And their customer service is the best in the country as far as if you need help with a case, you get them on the phone. I know that there even won there was a survey that went out, and they're going with the highest ratings in that. And I can personally attest to the fact that if you need some help with the case, if you have questions about the bite, if you know anything like that you want, they're there for you. And I know that Rich, you and I don't do a ton of other dental services, but back when I had my dental practice, we utilize them for a lot of things like implants and so forth as well. So if you're looking for a new lab for that as well, DSG, we can't say enough nice things about them, and I'm really, really happy that we're doing these webinars with them, and we're also doing a few courses coming up with them, which I think I have a slide up in just a little bit. So again, full service lab. We don't know as much about the other things these days because Rich and I just focus on the sleep, but I know that they can help you. One place can help you with all the things that you need in your dental practice. I know this Panthera 3D they're the only ones that make that. If you didn't get a chance to watch our last webinar, we did an hour on dental devices. You can find that on our YouTube page, and you can learn where this Panthera can really fit into your practice as well as the other devices that we have here. So, well, got a little carried away. The courses we're doing, I just got back from a course last weekend. As I mentioned, we're doing a course in Grand Rapids, Kansas City, and here, and get to do a course a little bit more local in Clearwater, St. Petersburg area with dental services groups. You get a dental a home sleep test there. We're going to do some provisional devices. It's a day and a half or almost a 2-day course. It goes into the afternoon on Saturday. And if you want to learn how to do this, this is the place to come. The normal fee is $9.95 for dentists. That includes a team member. So I think if you type in course, they might even give you a discount on it from attending this webinar. Oh, went the wrong way. Excuse me. Fat fingers here. Oh, and I forgot about the billing course. We got a billing course coming up Saturday. Rich, I know you're going to be in town for at least Friday for our member meeting, and then Lisa is doing the billing course. And Lisa, do you have anything you want to say about are you on here, about the billing course?
Yeah, I'm here. I'm super excited about the opportunity. We'll be covering a lot of information that's going to be imperative and beneficial for the providers. It's not going to be software driven specifically. It's things they need to know at that front end in relationship to Medicare versus Advantage plans, and also making sure that they're able to have those financial conversations and get that good idea about what that allowable might be and how to have those conversations with their patients.
Fantastic. Well, I think there's still a little bit of room there.
I think that's a great point, Lisa. Guy, that Lisa's pointing out is, I think sometimes the challenge is, how do we have that conversation with the patient? Is our service worth it? You're just getting started in this, and you're going to charge $2,500. You don't feel like maybe your service is worth that, but you certainly, as we like to say, Guy, fake it till you make it. How many of these have you made? Well, I made one yesterday. That's always my response, even though it might have been my first one. But, that's the kind of thing that you'll get at that course, too, is a lot of the verbiage that we actually use when we do a lot of that. And we can't go into a lot of that tonight, but we'll do a little bit.
Fantastic. And I think one of the things that you have to understand if you're new to doing this, the moment that you decide to make a mandibular advancement device here, you're making it on the teeth. But what you're actually doing is a medical procedure. You're doing a dental solution for a medical problem. And I think that's where we get sidetracked as dentists. We have to start thinking like doctors here. We got to play by the doctor rules. And the medical billing is way, way different, as we already mentioned, than dental billing. We got some things listed here on the screen you can look at. But just to hit the high points on some of them is, we can't make the diagnosis. Physicians need to. The way to determine you're paid is by your documentation, not by radiographs. They do audits instead of denying payments at the beginning. And the whole ethics behind medical billing and dental billing are different, because in some cases, medicine's life-threatening. It's arguably a lot more important than teeth. Breathing on the scheme of things is. And so you've got to think about this differently, and just imagine your last visit to your doctor's office and think about how they managed the billing procedure. Did they sit down and give you a treatment plan and give you, all these things that we do in a dental office, or did they treat you a little differently? And that's the mentality you need to adopt when you begin into medical billing for dental devices, because it is a medical procedure.
Big difference. You're crossing the line there.
Yeah.
Not to scare you again, but when they do a medical audit, they ask for their money back. They don't withhold money from you. They actually ask for it back. So, interestingly, when we think about, how do we get paid and how do we bill? We've all been taught since dental school, Guy. Hey, you charge $100, man. You charge $100 to the patient. You charge $100 to the insurance. If you do anything different than that, man, the police are going to show up tonight and drag you out of bed and take you to jail. And in medicine, I went to get some blood drawn the other day, and I was like, well, how much is this going to cost me? They couldn't even tell me. I mean, they just, I don't know. There's all these fee schedules and all this, and all this other stuff. So, when we get right down to it, I know you did a little bit of research, Guy, on where the American Dental Association stands on this. And this is what we've been taught. If we're not doing that the way we've been taught, then we're engaged in overbilling, and we're going to go to jail. So, but if we look at the American Medical Association, right out of their handbook, patients are made more conscious of their costs through co-payments. And when a co-payment is a barrier to needed care because of hardship, we can forgive or waive the co-payment. So I think we owe it to, everybody out there to make a reasonable effort to collect what we charge with every single patient. But, this is part of what Guy was talking about before when he said, there are some areas that are a little bit gray here. And again, we don't want you to do anything illegal, and we're not, supporting any of those ideas. But there are differences in how we bill, and you have to begin to grasp that as you decide how you want to do this.
Yeah, and this kind of makes sense, not to go too much further down this road, but if a patient really needs the care, and we can tap into some of their medical insurance to pay for part of it, but they can't pay for all their balance, is it unethical to do that, or is it more ethical just to say goodbye, we can't help you here? I mean, in medicine, they try to help the people, and that's why it's set up that way. So it kind of makes sense the more you think about it, because we want to help the patients, and we need to do everything we can to collect the money. The bottom line is, when all this is said and done, the patients want to know a dollar amount. And that's the tricky part when it comes to out-of-network billing, we're going to get to in just a few moments. They want to know, how much is it going to cost me? And they want to know that they're coming to an office that does this enough and is willing to help them with their medical insurance. Those are two things they want to know. So how much is it costing me? And well, yes, you all are going to help me with my medical insurance billing. I'm going to get them to chip some money into. And so you don't have to do medical billing to do dental devices in your office. You can, if you have a fee-for-service office, I did, Rich, when I first met you, I'm running my fee-for-service dental office, and my patients paid me for crowns, and we didn't deal with dental insurance. You know what? They paid me for dental devices, and we didn't deal with medical insurance at first. But what I found is, as I tried to expand out to get physicians to refer to me, I had to start dealing with medical insurance, or they wouldn't refer to me. So again, you can treat patients without even dealing with any of the stuff we're going to talk about tonight. But to get out there and to have physicians start working with you, they're going to not be readily excited about working with you if you don't manage medical billing appropriately. So we're going to talk about the things you need to have in order to do billing. So these are requirements that you have on the patient. When you check certain boxes on the form that say you have this information, and back to Rich's audit there, they may pay you and then come back and ask later, do you have these things? And then if you don't, they'll want their money back. So there's certain things you always have to have that are listed here on the left. And then there's certain things that you may need to have that are listed here on the right. I don't think we have to spend a ton of time on the top one. Sleep tests, obviously, they got to have a diagnosis of apnea. I guess that should say sleep test with diagnosis of apnea. We have to have some clinical notes. That's sometimes from the physician, whoever ordered the sleep test. So we got to contact their office and get that. If we ordered a sleep test, then maybe the questionnaire that we filled out will work. If they're severe apnea, then we have to have a notation that they're severe and that they've tried CPAP and can't tolerate it for some reason. In most instances, most insurances follow those guidelines. We have to know if they have coverage. We're going to show you how we do that with an instant eligibility check. We have to have a way of submitting it. I'll jump down here to the bottom. And we have to have them sign a proof of delivery, which is just basically them acknowledging that they got the device. It's just what you have to do when you have DME. They deliver oxygen to your house, you're going to sign that you received the oxygen. The one I think, so all that's pretty straightforward, I think. If there's questions, type them in and we'll verify. But this letter of medical necessity and prescription, I think is worth spending just a moment on. I'll describe it, and then Rich, you and I can talk about how we get this. But basically, it's a letter that says it's medically necessary for this patient to have a dental device. And then there's a prescription for the E0486. This needs to come from a physician, and ideally, it needs to come from the patient's primary care, or what do you always call it, Rich? Their best physician. Who's in charge?
Yeah, the best MD, we call it.
The best MD, yes. And this basically says from that physician that, hey, I want you to do this dental device. And one of the criticisms that the certain organizations say, and as people are talking about home sleep testing and the dentist hands, are, hey, can we do this without the physicians? I think if you use a home sleep test, you get a diagnosis from some doctor that never met the patient, and then you just go make them a dental device without communicating with the primary care or their best MD, you may be sticking your neck out a little bit, and it could come back, become a problem in the future. Do you agree with that, Rich?
I do. And remember, Guy, that we're looking for opportunities to market our practice and to get more patients in the funnel. And put yourself in that physician's shoes. And if you go, hey, what? Guy came in and you got him sleep tested, and then you made him a dental device? You didn't even ask me? You know, about you didn't inform me of any of this. So communication is the key. You know, I've preached for years and years, just pick up the phone and call the guy or the gal. Most of you won't ever do that. I know that because I've said it about 14,000 times, and I've only had 7 dentists do it. But at least write letters, you know, at least engage them. Even if you have the patient call the doctor and say, you know, so you've got to communicate. And we cannot, I cannot overstate how important it is that you involve the physician. When we say best MD, we're not talking about the best doctor in San Antonio. I'm talking about Guy's best doctor. That may be his rheumatologist, you know, that he sees every day for his arthritis, you know, or once a month. That's our best MD. We want the one that you have the best relationship with, because he's the one most likely to give us what we need as we talk about how we get this stuff.
And you have to have it if you're going to file a claim. So if they ask for that and it's not signed, you're gonna
you're out on a limb.
You're out on a limb. But this is also a medical, a legal problem or a legal concern too, that you're working with their physician. So I know we spent a moment on it, but it's important. How do you get this? Well, you know, Rich, I know you call the physicians up a lot. If you don't know them, you're trying to build that relationship. That's one way to do it. If you happen to have a copy of the sleep test, which you will obviously by now, you send that over to them, and we send we actually will fill one of these out from the physician to us, so that all they have to do is sign it. We fax it to them, say, can you please sign this? We have a cover sheet on the top that asks them to sign it. Then we call them on the phone and say, we just sent that to your office. There's a sleep test on your patient. We want to make them a dental device. We want to make sure you're on board. We made it easy. If you agree, you just got to sign this letter of medical necessity and prescription for the patient. So if you make it easy for them, they'll sign it. Now, if you call them up and say, please send me this, and they've got to type it up, it's going to be harder to get from them. So on the May side, pre-authorizations, those mean something different in medicine. That really isn't just to know how much they're going to cover, because they probably won't tell you that anyway. They certainly won't if you're out of network. It's really a process that has to be done by your third-party biller to get, before we start, they have to get approval ahead of time. So it's a little different meaning than you may be used to in dentistry. It's required. It's not just a option. Oftentimes it's required. So it's in the May side, but more times than not, it's actually on the side. And your third-party billers will be able to check and see if it is or isn't. So, and there's some forms
the fallback to that, Guy, I want to make sure everybody understands is, if you don't get permission, then they're not going to pay for it too. So you could have everything else in order,
Yes.
but you have to have it authorized before you actually bill it and do it. And if you don't get that, you go ahead and bill it and do it, even though you have everything that you would have had and you got the approval, but you started before then. So that's a big deal, and you have to make sure that you do that.
Absolutely, because you can't post authorize it. It's pre-authorization. Let's make that very clear. And you're dead in the water. They'll never pay for it. So those are the. Go ahead.
Let me add one more thing, Guy, too, as I'm looking through the questions, because this is an important point, too, is that most of the time, the prescription /LOMN, letter of medical necessity, can come from a PA and a family nurse practitioner. So
Sure.
I know in Texas, I don't think I've ever run into a case yet where that is the case. And I think Lisa answered that question and said, for the most part, yes, that's okay. But that's a good point.
Yeah, we'll go through these questions when we're finished. If there's any more clarifications, keep them coming in. We're typing the answers as we go. We have some decisions to make here, and we're going to start with commercial insurance. Do you want to be in network or not? And as Rich mentioned, other than Medicare, I'm not in network with the carriers. Why would you become in network? Well, number one is the allowable. You have a negotiation with them. Y'all still see my screen? Can you hear me?
Yep.
Okay, I got a little message across there. The allowable. So there's none of this guesswork involved. It makes the math a lot easier. The patient's deductibles and copays are typically less. That's the big ones. And so they'll be more likely to want to do treatment. The negative is the amount they allow is almost always less than what they will pay out of network. And so, Rich, why you're in network? What made you decide to be a network in the ones that you're in?
That's a really good question, Guy. And I will say, I believe that the biggest reason that I chose to do that was because of the perception that I have in the medical community in San Antonio now. In other words, the MDs, we will get professional referrals from more than 200 physicians in San Antonio this year. 200.
Right.
So the biggest reason I did it was that, because it has helped me grow my practice tremendously. The second biggest reason was I don't think I'm as good a salesperson as you are, Guy. So I need to know what that number is. And when I'm in network and I know that they allow $2,000 and they met their deductible and their copay's 20%, I know it's going to be $400. It's just a no-brainer. So I think those are the two biggest reasons, and maybe we'll hit on some of the other subtle things.
Yeah, and I'm not, and I think that we do have more challenges. We got to ask them for more money. We got to build value, but we get more per case. Sometimes 2, 3, 4, 5 times as much per case. So it kind of makes up. And we would suggest, if you're talking to 4-Pillar Billing, our billing company, and you talk to Lisa or one of our team there, that you start with the out of network, because that's where you are. We work with that, and then if we start seeing that that's not working for whatever reasons, there's in-network people in your area, and you want to make the change, then we can look to get you in network. But most of the people listening right now, I assume, I know, are out of network. So we're going to spend most of the time talking about the out of network. And you can apply for gap coverage, which means I'm in network for that one case, and then we agree to an amount on that. But there can't be anybody else in the area who's in network for you to get that. They don't always give the gap coverage, so it's kind of a little bit of a lengthy process, and there's no guarantee there. The disadvantage really is we don't know what they're going to allow, and there's also the patients often have higher deductibles and higher copays. So because we don't know what the allowable is, it becomes very challenging, and you can't call the insurance company and get it over the phone. The patient can't call the insurance and get it. In the vast majority.
You mean they won't give it to me, Guy? If I call them and say, do you allow 3,000? And they say yes, and then I go, I'm sorry, I meant 4,000.
Yeah, no, they won't do that.
That's exactly why they won't give it to you.
That's exactly right, because they don't want you doing that, and they won't even give it to the patient for the most part. So we're going to go over how you can kind of estimate that, and then if you work with a third-party biller, because they do a lot of billing throughout the country, then we can narrow this guesstimate in. That's never, if a third-party biller says, 110% of the time, this is what the allowable is. In every situation, I would question that, because no one can tell you without any degree of certainty unless you're in network. We can certainly narrow it down and help you with the systems for that. So I'm going to go through really 3 ways of doing this, and then kind of, well, 2 underneath the patient accept the risk, and then we will talk about the pros and cons of those. So in other words, if I don't know the allowable amount, I can go to the patient and say, you know what, I don't know the allowable amount. I want X amount of dollars for this, and you deal with the insurance company. I'm not going to deal with it all. So that's fee for service here. Patients, you know, what they get a penny back or they get all their money back. It's on them. And that works very well, except for your case closure is going to go down because patients will have to accept your full fee to say yes to treatment. But it's very predictable. No one gets confused. Patients are, you know, understand where we're going. The other way is to estimate the allowable. Okay, we're going to guesstimate it. Okay, now if we guesstimate it and we let the patient take the risk, I'll demonstrate that. And then we'll talk about if we take the risk and what the difference there. And then there's an option here that I know that when I did a webinar with another one of our DS3 members a while back, he talked about how he does the billing, and I'll mention that where you can just actually send them a bill at the end and bill it later, because that's what a lot of medical offices do, but there's some pros and cons to that. So the first thing we have to do before we do any of this guesstimation is we have to make sure that they have coverage. We need to call the insurance company, or if you work with DS3, with the click of a button, you can usually find out if the patient has coverage. If so, do they have coverage for the dental device, and what their in and out of network deductibles left to be met, and what percent of copay they have to pay with both in and out of network. So you need to find that out. You can do that with a phone call, which can take 5 minutes or 45 minutes, or you need a system like DS3 to find that out. Again, we're looking for the deductible left to be met and what the copays are, mostly for out of network. So we get a report that looks something like this. And let's just go with the first example where we're going to estimate this, but the patient's going to take the risk. And you can do the math. You can look at it here. I'm not going to spend a lot of time on that. But we're going to, you know, if after we do the math and we estimate their copay, we're estimating the allowable amount. And then we tell the patient, okay, look, it looks like that your portion is going to be $1,880 out of this $3,000 that this fictional number we came up with that we're going to bill them or want to collect. And the insurance check should be about $1,120 if you do the math after you know what their benefits are here. So we tell the patient, look, our fee is $3,000, but we're estimating $1,120 from the insurance companies coming in, and we want you to just pay the $1,880, and then you know, we'll get the rest from the insurance company. But in the fine print we put on there, if we don't get anything from the insurance company, you know, you owe us the full $3,000, and we tell them that, right? You know, a lot of offices that do it this way, Rich. I've talked to even other third-party billers that recommend this, and it can work. But what happens when the allowable amount was far less than what you?
It isn't 3,000. Instead it's 1,200.
Okay, what does that mean? Well, that was more than the deductible left, so that means no insurance check. So now we got to go back to that patient and go, well, our estimation was off, but because we don't want to take that risk, we're going to get the money from you. How's that conversation usually go, even though they signed something saying that they agreed to that? Do you think the patient's going to be happy? Usually not.
I've had better days.
Had better days. So you got to be really clear if you do it that way. I know a lot of people do it that way. It's probably my least favorite way of doing it, because I would rather just collect all the money at the time, let them deal with it, set the expectation for the full amount. That way when they get money back, they're happy. If you set the expectation that they probably aren't going to have to pay more than X amount, but then you're wrong, and then you go back to get the money from them, it's just typically not a fantastic conversation to have with the patient. So I think this is probably, at least in my opinion, my least favorite way, but it is the way some offices do, and it's, again, your choice. The other option is we take the risk. Okay, now we don't know what they're going to pay, so if that check's less than we think, we're done. We can't go back to the patient. We take it on the chin, right? If we're going to do it that way. Now, understanding if we do it that way, we have to, and we want a certain amount for a device, we have to collect more on some to get that same amount because we want to collect less on others. So you got to bill more than what you actually desire because occasionally you're going to be wrong. And you've got to come up with a system to do that. So when you decide if you want to do it this way, you're going to have to come up and decide how much you want for this. And if you want to break that down into one or two plans like I've done, that's fine, or just stick with one plan, either way. And then I would suggest that you have a cash fee discount so that if patients come in, they have really high deductibles, we'll take a percentage off. And that's not just to help them say yes to treatment. You're doing less work. You don't have to do all the filing.
A whole lot less work.
Taking less responsibility from audits. And so our deal is if you go with the cash discount, we do not file the claim for you. We don't, we don't
do anything. Yeah,
we don't help you file the claim. No claim is going to be filed. They need to understand that because a lot of times they're going to say, oh, can't you just go ahead and file the claim for me? And the answer to that is no. If you want to file the claim, then we're going to go through your insurance and we're going to go with the amount we desire there. So you got to come up with these amounts. I might have some examples here for you, but understand you've got to come up with your own amount, and you got to come up with this estimated allowable. And after you do this for a while, you can narrow that down to where you're getting it more precise. And the more you do, and the more you work with your third-party billers, the more they can help you with this estimate. But again, it is an estimate. You're never going to know 100% of the time. So sometimes you're going to overshoot, sometimes you're going to undershoot. So the kind of the way we walk through this in my office is, and again, with Rich, he could talk about in-network billing, but it's pretty easy. You check, you know what their copays are, you do the math, you know how much they owe. When you're doing out-of-network, you need to have a check to see how much their copays and their deductibles are. Now, you do that as well, but then if you're in network, we could draw an arrow over to the right. All you do is look what their copay and their deductible, and that's what they owe. And that's what the check's going to be for. In our case, we don't. We call this the MOOT, which is the maximum out of pocket, or you can call it the copay, depending on how you discuss that with the patient. So we're going to plug in a number for the amounts that we want for plans A and B. We're going to plug in a number for the estimated amount. And then we're going to do the math, and we're going to go to the patient and say, here's what you owe. And if we're wrong, we eat it. If we're wrong on the other direction and we get more money, we benefit. So you have to have a tolerance for that as you go through this. So I'll give you one example of this, and then we're going to move on to Medicare, which, believe it or not, Medicare is a whole lot easier. I mean, you don't think that Medicare is easier, but it is.
Yeah, I never thought we'd say that, 5 years ago, but you're right. It is now. Hasn't always been.
Absolutely. It is, you have to have all the documentation, but as far as the billing part, knowing what they pay, it's much easier. So let's say you do decide to do two plans and you come up with $2,800 and $1,950. If you want a cash fee, you come up with those, and we have a provisional fee. Okay, and let's say we estimate the insurance allowable to be $2,800. Okay, that's what we've talked to our third-party biller. We know what we're billing, and we think that's the best guess as we can know of what they're going to allow. We do the instant eligibility check. We have a $900 deductible, 70/30 coverage. For our billing clients, we will do this for them or help them. I have a little cool calculator that calculates this, but it's not any magic math here. All you do is you take the 900 off the 2,800, okay, and that's how much is left after their deductibles paid, and the insurance check should be for about 70% of that, right? Because it's 70/30, so it's 1,330. So if you have your plan A, you subtract that from plan A, plan B, and that's the patient portion. So it's just simple math. The problem is we're not 100% sure this 2,800 is going to be the allowable amount. So they may allow more, they may allow less on any given case. So you just plug those numbers in. We sit down and talk to the patient, say, here's what I think you should do, and we give them our plan A and say, this is our best device, this is our Panthera device, this is our Somnomed Pink series, the ones that we guarantee for 3 years because those devices hold up great, and we love delivering them because they just fall into place. And the patient says yes to the 1,470, we're done. Okay, the patient says, oh, I really can't afford that. Then we say, well, we got some other devices that we can do. We might go with the Somnomed Air series, the blue ones that are a little less expensive. We may not warranty our device quite as long. We may minimize some of the sleep tests we do in our company and on our office rather, and the amount 620. Can you do that? And they say yes, we're up and running. Now, obviously, in this scenario, we wouldn't want to go with the temporary because that's lower than the custom device because they had some decent coverage. If they say no to everything, then we look at doing the gap coverage. So that's how we do it. We don't accept assignment of benefits. The checks go to the patient, and the patient, whatever insurance checks that they get, they need to deposit and then give to us, is the system that we use. They do stiff us sometimes, but the most of the time we get our money from our patients, and that's a way you can estimate this and kind of take some risk, but you've got to have some tolerance for up and down. Whatever you decide to do, make a note of it. Have a financial agreement. Make sure everybody's on the same page. We, in DS3, we have a place in our ledger where we put notes, anything to do with money. I don't think needs to be in progress notes. It should be somewhere else. And in our software that we use, they go right into the ledger notes. So we're talking about money, we go to the ledger, and there's our notes with that. Did I lose you, Rich? Because this is not exactly how you do it.
No, I think that's, you do a good job of explaining that. It is a little bit complicated. And again, we do record these. You guys can go back and look at this again. And I think within an hour or two, Guy, most offices can figure out this, and they can figure out what they have to do. But you have to, quit doing the root canal, and you got to just concentrate for a few minutes on this and focus with your staff on how you want to do this. And once you get a couple hours into this, and then you do it a certain way, and you get some feedback about how that's working, how many patients are accepting treatment. I really believe, Guy, that this is kind of a geographical thing in a lot of ways, because we know dentists that they couldn't sell their anything, and they do great in dental sleep medicine because they're in an area, or they may be in an affluent area where people don't care about money. I mean, you have to evaluate all of these things in your practice as you do that. And you have to figure out, you've heard Guy and I do this completely differently, and we've both figured out a way to do it successfully.
And I think, Rich, what you said is important. When you decide to do this, have a meeting with your team, get the counsel of a third-party biller, let them talk to you about these options, and then make sure you fully understand the system that you're doing. I think that's key. One question came up: can I accept assignment of benefits and do it this way? I can, but if they only allowed $1,000, then I have to base everything off that. And so I don't recommend doing it the way I'm currently doing it, because then you lose the upside as if they pay more, because then you got to go back and readjust all the math. The other way, we talk about systems. I know some dentists that do it this way. I've done it this way in the past. You go to the medical office, they just say, hey, you need to have this procedure done. You sign some papers. Oh, we'll bill you. Your medical insurance covers it. And they do. They bill it, and then they take your deductible, and you get a bill for your copay. And so in this case, you accept assignment of benefits. Whatever they allow, you accept. You bill the patient their portion, their deductible, and whatever their copays are. It works great for getting patients to say yes to treatment. You better darn well have really good people to follow up, because you've not gotten any money from these people, and they're walking around with a dental device, so they got to go be the bill collector here. And when they go, my God, I had a $5,000 deductible, and this costs so much money, I didn't know it was going to be so much. You better have a solution for that, which oftentimes is giving them a prompt payment discount. Or you can say, well, we'll help you out here if you'll pay us right now. And you got to have somebody who can smooth that over. But I know offices that do really well with this particular billing model. It kind of kicks the can down the road, and so you got to have better systems on the end than better systems on the beginning. So those are the options you have. Whether you bill for one code or all the codes, I'm going to make this simple so that we can get on to Medicare. Unless you're really know a lot about billing and you just came on to hear Rich and I talk, if you're new to this at all and you feel you need more help in this area, I would not recommend billing every time the patient comes in for an office checks and all the other codes you can bill to start with. One fee, one code for your services for that dental device will make it simple. We do have offices that successfully bill for other codes, and you certainly can. But since
you got to know what you're doing, you have to know what those requirements are.
Yeah, absolutely, and we have a whole hour-and-a-half webinar on just those requirements. That's how complicated it is. So remember, I think just the key things on here. Number one is whatever you bill the patient, let them know that's how much you're billing, because they'll see it on the on
EOB,
the
anyway.
EOB and go, oh my God, I didn't know you were billing this much. So let them know the billable amount, and then let them know really what you're planning to do going forward. I think what most of this rest of this says here, and so you have it documented. So there's no, what I don't want is the patient to be confused about where we are, the team to be confused. We need to have a good paper trail so that we know who owes us what. Want to mention our next webinar coming up. As we got to get into Medicare in a minute, but this is very exciting. We're doing one with Jamison Spencer, who's one of my mentors as far as TMD goes. If you want to learn about TMD, I don't know of a better educator in the country. I'm really excited to be on with Jamison in November. And Rich, you're welcome to join us too. But if you want the night off, Jamison and I will we'll be talking about how to deal with the most common side effects of oral appliance therapy. I'm certain I personally will learn something from this. And if you've not heard Jamison talk, then really you don't know what you're missing. Tune in for this. And if you haven't heard him, I'm sure you'll want to, because you know how good it can be. Also want to mention that if you're interested in what we do, just type in consultation, and we will be happy to get on the phone, talk to you about how we can help you in your dental offices, implement dental sleep. That's all we do at DS3. And also that we have our symposium coming up in February. Jason Tierney puts this on each year for us and has really stacked the deck again. I don't know how he keeps getting all these great people, but it's in February. I don't know where everyone lives, all over the country, lots of you. Likely the weather will be as good or better in Clearwater, Florida on February 15th and 16th, I think is the date, 14th and 15th rather. Great room rate at the Hilton, so try to come see us there. We're going to talk about Medicare, and I know that we really went into a lot of detail on commercial, but Medicare is easier. Rich, I mean, it's we know the allowables in most cases on this, and that's what makes it better. And I think, Rich, you put this in the slide. That's the right thing to do, right? These people, you and I work, and your grandpa now, does Medicare seem more important than it did 10 years ago?
Well, it's closer today than it was yesterday, I'll tell you that. So yeah, you bet. And it's not welfare, I mean, and when we talk about the mega trends in our society, we look at, there's like 10,000 people a week who are turning a Medicare age in the United States. I mean, it is, there will be millions of people here. So if you ignore Medicare, you will be ignoring a very big plus upside to your dental sleep practice. And I do believe, Guy, that the reimbursement will start coming up, certainly for the region that you and I are in, Texas and Florida, because they're just, their Medicare has a lot of rules, and they have this. That's the bad part. But the good part is, at least they tell you what the rules are. And then they tell you what they're going to pay, so we can tell the patient what they're going to pay. So a lot of that stuff that we just talked about, which is when the patient says, hey, how much does this cost and what my insurance going to cover? Well, it depends. Right. We don't have to say it depends anymore. We say, this is what it is. And now we have the rules for what we have to have and how we have to do this. They even have rules on the diagnostic side. You have to meet certain requirements with your sleep test. It's not okay that you just have a diagnosis. So again, at least we know what those rules are. And Medicare's, broken up into 4 different jurisdictions. And DME is the durable medical equipment. That's what they've classified our dental devices as. And if you happen to live in the Northeast, you're the lucky guys. I guess that's where the, the ship landed in 1620, right. So I guess they get the best deal still or something.
Yeah, and to clarify these, the 1916, again, time stamp this is October 1st, 2019. These do change. It doesn't necessarily mean they'll go down. We hope some of them will be going up. 1916 is roughly the amount they allow. Medicare pays 80% of that. That's what this 1526 is. The patient pays the other 20% if they don't have supplemental insurance, but most people do. So their supplemental insurance typically covers that amount. Sorry, I wanted to make sure we time stamp that too, because these things may change.
The different jurisdictions cover different amounts, and there's no rhyme or reason for why this is, other than the fact that they're managed by different healthcare providers. So we do think that there's going to be, you know, some consensus eventually coming out of this. And we certainly hope for us in Texas and Florida that that goes up, you know, because we're the lowest.
Yeah, I went through those. If you didn't get those, by all means, contact us, and this webinar will be posted on our YouTube page, and you can come back and review it. As you start treating Medicare patients with dental devices, you're supposed to make a decision. You need to decide if you're going to opt out or become a Medicare provider. And if you're going to become a Medicare provider, you want to be a participating or non-participating. I would say you either go with one, or we have a strong preference for 2-2 there. You should become a Medicare provider, but a non-participating Medicare provider, because as a non-participating Medicare provider, you have some options. This accept assignment of benefits becomes means a whole different thing for a Medicare patient. Well, not a whole different thing. The checks still come to you or goes to patient. That part's still true. But as a non-participating Medicare provider, once you apply and fill out the forms, and we can talk about that, and if you need help with that, we have done, I think, over 50 Medicare applications this year in our 4-pillar billing company. We are experts at doing that. We can help you with it. But once you become a non-participating Medicare provider, if you live in our region and I accept assignment of benefits, then I'm going to get the patient's check and the supplemental check, and I'm going to get $1,100 roughly. Or because I'm a non-participating provider, I cannot check that button, and I can ask the patient to pay me whatever, and the checks are going to go to the patient. And you know, if your normal fee is above the $1,100, then you can do that. And so in Florida, I often don't check assignment of benefits because $1,100 doesn't make me as excited as a little bit more than that to do this. And so we find out really, you know, how we offer a couple of different Medicare plans as well, so that we can get a little bit money above and beyond the $1,100. There are forms you need to fill out. They're called advanced beneficiary notices. We could spend 20 minutes talking just about that, or maybe even an hour. Again, why you need to talk to 4-pillar billing or what your third-party biller about how and when you fill these out. It's real important to know how and when. The way I do this for Medicare is very similar, but see how much simpler this is. And then a lot prettier than the other one. We have 2 plans, and we know how much the patient is going to be out of pocket. So we basically just offer them the plans, and those plans come with little sturdier devices that are milled versus non, versus maybe me doing sleep testing in my office. So you can kind of decide what goes in those plans. And so if the patient can't afford the top end treatment for their portion, then we go to B, and then we can always accept assignment of benefits, which I do. And I have a plan that allows them to do that as well. And so I get $1,100. The patient still gets treated with a device that's not my favorite device. It's one that I don't feel is quite as comfortable. It's what we call snore hook. It's a very inexpensive device, but at least we get them in some sort of treatment here. So you can plug your numbers in, and the patient can pay you, and the checks can go to them, or you can collect part of the payment, however you want to do it. It works out to be very easy. So you can see how much easier Medicare is. Why? Because we know the allowable. You just got to go back to those maps and look at the allowable amount. So regardless.
Let me reiterate one thing there, Guy. Go back one slide there.
Okay,
remember the jurisdictions that we showed with the 4, okay? If you're in that jurisdiction in the Northeast where they allow $1,900 and they pay $1,500, when you check accept assignment of benefits, that's the contract that you're agreeing to.
Thank you.
Yeah, so you know what you're going to get. Again, that's why this whole thing, it makes it simpler. I don't do this the exact same way Guy does. You know, I don't offer plan A and plan B. I just have one plan. And that's okay. Again, there's different ways to do this. We're trying to show you guys that knowing what we know, we both choose to do this different ways, and yet we're still successful at doing that. And so if you know that, you guys all put your heads together, you can figure this out.
Yeah, but everyone has the option of accepting assignment of benefits or not. So if you're in New York and you want $2,500, then the patient's going to be out $600 ish by the end of the day, because you're going to get $1,900 paid back to them, assuming they have supplemental. So you could offer them that, but if they can't afford that, you can always accept assignment of benefits. the checks come to you and the patient pays nothing. Most cases because they have supplemental insurance. So in Florida, we can do that, but we only get 1,100, which is kind of a bummer.
Same in Texas. But you know when I do that, Guy?
Yeah.
Do you know when I
do it for the same reason. Yeah, go ahead.
Yeah, a little old lady comes in and I fall in love with her, and she does it. Or a little old man comes in and he mows the yards all day, and then he fixes air conditioners at night or something like that. So, if I just really like these people and I do that, and is that wrong? I don't know, but that's still.
Well, I thought
the nice thing is it's our option, and we can do that or not do that.
And I do that too. And the other reason I'll do it is if I've spent a long time courting a referral source. So, we've sent them letters. I went and did a lunch and learn, and they say, how much is it going to cost my patients? I say, hey, with Medicare, we have an option that costs them nothing. That's what we tell them. And say, oh, great. And then they come in, hey, the patient comes in.
Sends his mom over too, no doubt.
Sends his mom over. I'm going to give them the best device I can make, and they're not going to pay a penny. I'm going to check accept assignment of benefits, and I'm going to get my 1,100 and be thrilled about it, because now they're going to send more patients over, and then at some point I can start doing it differently. So, the bottom line is, we've talked to this at a high level. It is complicated. I know that there's probably some things that have left a little bit gray for you because you've got to make these decisions yourself. But what you have to do is have a system that you and your team embrace, and the less that patient has to write you a check for, the more of these you're going to do, and the more referrals in particular you're going to get. I think that's really what it boils down to. If you use DS3 and you use our company, 4-Pillar Billing, or even some other companies that we work with, we make this billing process seamless. You don't have to fax over sleep studies, letters of medical necessity. All that stuff lives within our cloud-based system. You click a button, the 4-Pillar Billing has their access to it. They process the claim, they communicate with you to the extent that you need, and then the claim comes right back into DS3. It's very, very seamless. It takes a mountain of paperwork and diminishes it to a few button clicks. So if you want to know more about what we do and how you can get paid for saving lives, just type in consultation. We can show you how our system works. And even if we just want more clarification on this, we're happy to talk to you about the systems that you can put in place to make this work. Because I think what a lot of people don't realize what we do have the best cloud-based dental sleep software out there and system, but we also provide an enormous amount of training included with our system to help the dentist get over these hurdles, such as billing and which device to select and what you do when you have side effects. All these things are what we help train you on, and we'll be happy, even if you're not a member, to sit down and just talk to you about how we can help you more and answer specific questions. So if you type in consultation, we'll be happy to discuss that with you. And this is about money, so we thought we'd include this slide again, where you can look at the return on investment. Even if you're getting $2,500 a case and $350 lab bill, and you're paying your third-party biller, even if you pay for DS3 for the year and you do a device a month, a device a month, Rich, how 1 in 5 adults has this? You're going to do a device a month, you're pushing 20 grand you're adding to your practice. Do it once a week and take 4 weeks off, you're just south of 100 grand, just south of 6 figures here in your practice. So there's not anything that you can really do in dentistry that has the upside potential for DS3. And I forgot to mention this at the beginning. I should have mentioned that we have this special offer from DSG. If you want to take advantage of this $50 towards your first sleep case, you've got to go to dentalsleepservices.net/DS3, and it's it's $50. Why not go do that? If you're new to DSG and dental sleep, then go there. You'll get some marketing material and $50 towards your first case. And they're so confident, as we are, that the services they provide, you'll be coming back for more as you do more dental devices. So take advantage of that. We really enjoy working with Dental Services Group. They have a whole suite of appliances that we discussed in our last meeting. Literally all the devices that I provide in my practice, we can get from DSG, so we don't have to go anywhere else other than them for this. So again, it's dentalservices.net/DS3. And we already mentioned this just a minute ago. And there's our courses again. Rich, are you looking at the
Question.
Are you looking at the questions here?
Yeah. Our team has done a fantastic job of answering all these. There are a lot of really good, can you bill this and not bill that? Do you do this and that and all that other kind of stuff? So I think, Guy, thank you again for putting that together. I think you've done a great job of trying to make something that's a little bit complicated and tried to simplify it a little bit. And I would just add that you don't have to reinvent the wheel. When Guy and I started doing this, man, there wasn't even anybody to call to ask how to do this. There certainly wasn't a webinar, on how to bill and how to do this kind of thing. So, we're here to help you. It costs a little bit of money, and it's some of the best money you will have ever spent in your entire dental career, if you decide to engage dental sleep medicine and do this, which I think you should. It's a very rewarding work. It's the right thing to do. Sleep apnea is not going away unless somebody invents a pill, that cures it all, which I don't think that's going to happen. And when you look at, what the powers that be out there say, man, sleep apnea will be one of the biggest burdens on the entire healthcare system in the next couple of decades. You look at the mega trend of Medicare patients that are getting older and how many have sleep apnea. I just think that, we are really shooting ourselves in the foot, Guy, as dentists, if we don't engage this and start doing it.
Right.
And it's just that the time has passed. To me, it's irresponsible not to at least screen your patients and refer them to a dentist in your area who does this. And most of the dentists on this webinar want to do this, and they're engaged in it. And we applaud you for that, and we want to encourage and help you any way we can.
Absolutely. Well said. I know we left some answer, not in the box up here on answer, but I know there's some gray areas. Feel free to reach out to us, type consultation, give us a call. Lisa, was there anything that you want to clarify more? I know your fingers probably numb from typing in all the answers here to the questions, because anything you want to clarify or add?
Yeah, my fingers are numb. So, but yeah, a lot of great questions tonight. It's always amazing to be able to answer that and provide feedback. We did have a couple of people ask very specific questions, so we'll be reaching out to them in the next 24 to 48 hours and getting those answered. But yeah, some of the things that we're able to provide as far as like the MOOC calculator and the forms are embedded in DS3, which are phenomenal. So we had questions around the forms. So the questions are, like I said, phenomenal. We'll be glad to answer any questions afterwards as well. They can give us a call and at DS3, and we'll be glad to answer any of the questions. And I hope a lot of people are going to be coming out to the billing course, because I'm really excited.
Yes, fantastic, Lisa. And again, if you just want to talk to Lisa on the phone, reach out to us. She'll set up a time. She can answer your questions, talk about how we can help and clarify these things. Just go out and start doing this. I always hesitate, Rich, when we do billing, because I feel like people get all excited and they go, oh, this is just too much, I don't want to deal with it. It's very, very doable. We have hundreds and hundreds of offices that we actually just do the billing for, in addition to all of our other DS3 members who do some of the billing themselves after they get enough experience. It's certainly a hurdle you can overcome. So don't let that stop you. Also, just start seeing your patients, doing the screening and doing some devices on your friends and family. You will see how much you can change these people's lives, and then actually make a profit doing it. So again, if anybody, I think someone mentioned they want to see the courses here again. I think it's right here. There's the courses. If you type in course, I know they'll give you a discount. I forget how much it is. But I think it's a few $100s off the courses maybe, or something like that. If you want to type that in, then to secure that, the upcoming courses, at least not the billing course, but they'll give you a discount on the course in Grand Rapids, Kansas City, or Clearwater. Those courses again are just where we sit down and from start to finish how you implement dental sleep in your practice over a 2-day period. You will leave there with all the information you need to do that. So I think we answered that. And is anything else? other questions we have up here? Rich, do you see anything in here we need to answer?
Boy, there's a bunch of them still coming in. So
okay, well, let's see. I'm happy to stay on it if we can.
We'll stay on for a second, to get some of these. So
yes, as a DS3 member, you get a discount on the courses already. So make sure you come to them. You'll get a lot out of it. I answered that one. What's this one here, Rich? You have an answer, or Lisa? Does anybody have? Well, my screen just started doing something weird here, but.
One of our insurance companies, Highmark in Pennsylvania, requires a trial with CPAP, has failed or is contraindicated as a requirement for a dental device. How are you getting physicians to adjust this? Sometimes they're saying the patient does not want to try CPAP. This is typically with the low and moderate level. It seems that the insurance wants a medical reason. Yeah, these, again, this can be a challenge, when an insurance company says, look, the patient has to try CPAP before I'll make you a dental device. That does not happen very often, I will tell you, number one. Number two, we have the patient sign the affidavit for CPAP intolerance. So even though they haven't worn it, they can still sign that piece of paper that says, I'm claustrophobic, I'm get anxious, I'd be afraid I was going to choke. I know there's no way I'm going to wear that. That's always our first response to that, as we try to overcome that. The second response that we have to that is we just tell the patient, look, get the CPAP.
Right.
Just get it. Try it, keep an open mind, see how you do, give it a couple of weeks. If you can't wear it, return it, and then we'll make you a dental device. It doesn't make sense that an insurance company would do that. And I think fewer of them are doing that as time goes on. But again, they're the ones holding the money, and they make the rules, and we have to be smart about how we do this, and et cetera. I went to my rheumatologist the other day, Guy. I'm getting old now, so I'm a grandpa. And my hip was hurting, and he goes, hey, we need to take an x-ray. I'm like, an x-ray? What good is that going to tell us? He said, absolutely nothing, but your insurance company won't pay for an MRI until we do an x-ray. So we had to play the game, that's kind of like what we're talking about here. So
yeah, and they can try the CPAP for one day and take it back. As one, and then I know for at least we don't of course know your specific insurance you're talking about there, but if they're basing that on some Medicare guidelines, Medicare doesn't say they have to try CPAP for severe. That's one option. The other option is if the physician writes a note saying it's contraindicated for this patient, that works as well. If you read the, Lisa, you can chime in if you know specifics on that, but I know that in the Medicare guidelines, there's an option for the physician to say that this is not indicated for that particular patient. I believe that works as well. Of course, you got to get them to do that. Is that correct, Lisa?
Yeah, that is correct. If somebody needs some additional information about that, we can give them the LCDs and quote some things to them and give them some feedback about how they can manage that. We'll be glad to do that.
Fantastic. And then the other part of that question, Rich, I think they mentioned for mild apnea, we'll go ahead and talk about that for just a brief second. In Medicare in particular, and some commercial insurances, and so if Medicare does it, you got to think a lot of the commercial insurances might do it too. If they have an AHI below 15, they often need to have comorbidities before the insurance will cover it. What comorbidities? Medicare lists 7 of them, which are hypertension, excessive daytime sleepiness, ischemic heart disease, psychiatric problems, mood disorders, and cognition problems. Boy, I got all 7 of them, I think.
And a partridge in a pear tree.
Yeah, there you go. So sometimes that is the rule. Again, I know we're sounding like a broken record here, but your billing companies will help you understand which insurances have those requirements. And even if you become a master at this, what will happen is they change the rules all the time. And so if you're doing it by yourself, if you're out in the island by yourself, you're not going to find out till the rest of the world learns through their third-party biller that the rules have changed. And so one of the advantages to working with third-party billers are certainly someone is the first one to see the rule change. But, it's like Russian roulette. If there's hundreds of people filing these claims, it's not likely going to be you. So someone else's claim gets denied for some reason, and then our billing company knows that the rules have changed and we can adjust accordingly. So there's a lot of specifics like that you have to know all the exceptions and rules for each of the particular claims. Is there anything else we didn't get to?
No,
Can I
I
repeat those?
think
I don't know that I can repeat those 7 comorbidities. I got lucky to get them right the first time. I'll try it again. You can look it up, or Lisa. Well, I tell you, better than that, Lisa, if you want to reach out to the member here who's asking about those, and make sure that Lisa will give you her contact, and she can email those to you or give them to you in case I screwed it up. I think I got it right, but it's possible I missed one, but I think I got all 7.
I'm pretty sure you got something wrong, but I don't know what it is.
At least you don't know enough to know which one I got wrong. So I don't know who knows more or less there, but you're probably right. I got one wrong, but she'll reach out to you to set that up.
Well, thank you guys for spending some time with us this evening. We appreciate you taking some time out of your busy schedules. And again, don't hesitate to reach out to us. All we do is help dentists succeed at this, and we can help you too. So
yes, absolutely.
Thanks again,
well, Rich, congratulations again on being a grandfather, and it's a good job here. And everyone have a nice evening. We look forward to seeing you on the next one.
Bye-bye.
We'll see if I can end this thing. There we go.